Morning everyone, welcome to Unacademy where you can crack all NEET PG exams with us with our top educators, our quality content and have a great learning experience. So guys, let's crack NEET PG together. A little about me. I'm Dr. Sasha Menon Remedies. I've done my MBBS from Father Muller Medical College, Mangalore. My MD in Anesthesia from Father Muller Medical College, Mangalore. I have 2 publications and 1 paper presentation in the field of anesthesia, and I have been working and teaching in Bangalore for the past 2.5 years. Today's topic will be Regional Anesthesia Part 2 continued. We will revise Regional Anesthesia Part 2 and continue the remaining part on Epidural Anesthesia. So Regional Anesthesia Part 1 was actually, we dealt with spinal anesthesia, and Regional Part 2 was, we dealt with epidural. Now we'll just revise the epidural anesthesia. We shall continue with the epidural and finish this topic. So let's crack NEET PG with one of India's largest learning online platform, that is Unacademy, which is going to help you all crack this exam, where you get plus subscription, access to unlimited live and recorded courses, and all from India's best educators. Now, what will you get out of Unacademy? So basically, Unacademy, we have our daily life classes. So when you go to a coaching institute, you can't really so you're going to a coaching institute, you have to get up in the morning, you have to get ready, or whatever, evening, whatever it is, you have to get up, you have to get ready, you have to mobilize yourself, you have to reach there. It's a waste of time, it's a waste of your energy. But with Unacademy, the classes are all from where you are, from the comfort of your zone. Then again, once you reach the coaching institute, you have to it's about the place. You have to get a place where you can hear the instructor, because it's a little difficult if you're sitting at the back and all that. It's a little difficult to interact with your instructor one-on-one, right? Even your concentration as such goes, but here you have your instructor right in front of you. You can chat with your instructor, engage in discussions, clear your doubts and answer polls, and all this is while the class is going on. Over there, it's a little on the other platform, it's a little difficult for your instructor to, or in the coaching institute, to really clear your doubts, because it's such a big class. He or she has a limited time frame to finish what he is supposed to finish and clear everyone's doubts. So it's a little difficult overall. So that's about our daily life classes. Then we have our structured courses. So all our courses are structured, and they are in line with the exam syllabus to help you best prepare for it. So all the courses are structured, and it has been researched, and they are all in line so that you can best prepare for your exam. Then we have our live tests and quizzes, which will help you all evaluate your preparation on a regular basis. So we keep conducting, as we take our topics, we conduct tests and quizzes, and then we conduct a mega test where we kind of combine all the questions and discuss the answers. I think I will be conducting a mega quiz, I think sometime next week, somewhere towards the end of next week, and we will see how all of you all fare. But overall, it is that's how we will go about it. And then of course, there is unlimited access, so you have unlimited access to it's a one-time subscription, and you all have access to everything. Okay, in the sense, access to everything in what ways mean? I mean is, you get to watch all the live recorded courses, all from the comfort of your devices, from the comfort of your home, and from a single device, and while sitting at home, you all get to watch these classes. These are some of our top educators. Dr. Nikita Nanvani, she is a NEET PG mentor, as well as in radiology, as well as mnemonics and concept focusing. And she on must know topics, she encompasses mnemonics and concept focusing, and she also she makes mnemonics on various topics. I would advise that for mnemonics wise, you all should make your mnemonics, as it is very, very important. Dr. Mohammad Azam, Dr. Preeti Sharma, and Dr. Divish Mishra. Then we have, these are some of our courses offered. As you can see, there are 19 courses, and we have various 19 subjects and various courses under each subject. So y'all basically y'all can subscribe and see. Now these smaller subjects like anesthesia, psychiatry, radiology are offered around 11 points. During your MBBS, you all never really went into depth into these subjects, because I mean it was like what, 1 month or 15 days you all were posted their internship, etc. So you all don't really know, none of us at that point just before post graduation really know in depth about these subjects. These subjects are vast, these subjects are really huge, and so you all just touch the cream of the cake, right? So even over there, even over in the exam, it will just be the superficial part. They won't go into depth, they won't ask you all in-depth questions like how they can ask in anatomy and physiology. So it's very easy to score in these subjects, is what I am trying to say. So don't leave these subjects out, kindly, please. um, don't leave these subjects out. Please uh, concentrate, focus on them, uh, and score your points here. These are some of the ongoing courses on our platform: neurophysiology course on neurophysiology, GI surgery, cardiovascular thoracic surgery, respiratory system course on larynx and pathology. Then we have, I'm sorry, I'm not keeping too well. Then we have NEET PG. Now we have a subscriptions. So as you can see, there are 5 types of subscriptions on your screen. A 6-month subscription should be enough for a 6-month subscription. Just a sec, guys. So a 6-month subscription like this one should actually be enough for those who are giving NEET PG this year. But if you are planning next year or something, I would highly recommend you all go for the 12 and the 24-month subscription. These are more economical too, because you all want to take your time. There's nothing wrong with dropping a year, nothing wrong with taking your time. In fact, it's only knowledge you all will be gaining at the end of the day. You all can go into depth into the subjects. Also, like I said, the smaller subjects, you all don't know much about it, right? So you all might be focused on medicine or surgery. You all want to take medicine or surgery, but you all don't realize that while studying, you all might actually realize, oh, I don't want medicine and surgery. I actually kind of like anesthesia. I'm actually kind of enjoying psychiatry. Maybe I want to do this, because you all are taking this up for the rest of your life. So you all gotta like what you all do, is my point. So again, 12 and 24 months, please do subscribe and see if you can, if you use my code. Even the 1 and 3 months quite frankly is not worth it, but 6 months, if you all are planning to give this year, use my code Sasha and you all can get your 10% discount. So with the 6 months, with the 10% it will be 18,000, and with the 10% for the 12 months it will be 22,500. Now again, coming to the 24-month, like I said, it is more economical too. And how is it more economical? Because it is a one-time procedure, and it is a, like I said, it is a one-time procedure. So these it is a one-time subscription. So after 6 months, you all will have to subscribe again after 1 year. And so if you all want to take 2 years, there's nothing wrong with that. Please go ahead, take 2 years. It's at the end of the day, it is actually just beneficial for you all. So please don't hesitate, subscribe, use my code and avail your 10% discount. So our topic last time was basically epidural anesthesia. right? We'll just go through it in brief. I have a few more points that I would like to bring across to you all. So epidural anesthesia produces a reversible loss of sensation and motor function, much like spinal, with the exception that the local anesthetic is placed in the epidural space. Of course, we know that. And larger doses of local anesthetics are required to produce anesthesia when compared to spinal anesthesia, and doses must be monitored to avoid toxicity. So an epidural catheter, so in the epidural space, an epidural catheter will be placed, which allows the versatility to extend the duration of anesthesia beyond the original dose by administration of local anesthetic. So because we put the local anesthetic in the epidural space, the duration of anesthesia can be extended. So epidural catheters may be left in place for post-operative anesthesia. So now the indications for epidural anesthesia are cesarean section procedures, of the uterus, perineum, hernia repairs, genitourinary procedures, low extremity orthopedic procedures. Excellent choice for elderly who may not tolerate general anesthesia. So basically the similar indications which are to spinal anesthesia. So it should not be used in patients who are hypovolemic or severely dehydrated. Basically in dehydrated patients where there is dehydration, this should not be, preferably not be used. So the high failure rates are present for procedures of the perineum. So lower lumbar and sacral nerve roots are large and they are hence a little resistant. Lumbar and sacral, basically your lumbar and sacral nerve roots are large. They are large and there's increased amount of resistance to epidural. There's increased amount of epidural fat which may affect your local anesthetic penetration and blockade. So this is known as sacral sparing, right? So the lower lumbar and sacral nerve roots are large and there is increased amount of epidural fat which may hence affect local anesthetic penetration and blockade. Like I said, this is known as sacral sparing. So the epidural anesthesia advantages: it is easy to perform, though it takes a bit more practice than spinal anesthesia. It is a reliable form of anesthesia, provides excellent operating conditions, the ability to administer additional local anesthetic increasing duration, and the ability to use epidural catheter for post-op analgesia. Now, your epidural anesthesia advantages. Um, the return of the GI function generally occurs faster with general anesthesia. Can maintain a patent airway, fewer pulmonary complications, and decreased incidence of DVT and pulmonary emboli. So with the epidural anesthesia, ambulation is quicker. So basically, the patient can ambulate quicker because the pain is taken care of, so the patient moves around quicker, and hence this decreases the incidence of DVT and pulmonary emboli. Okay. The return of GI function also comes back quickly and fewer pulmonary complications because we are not fiddling with the airway. However, the disadvantages are there can be risk of block failure. The rate of failure is higher than with the spinal anesthetic because there is no confirmation of basically backflow. So we don't have confirmation that okay, we are in the epidural space. It's basically by a loss of resistance technique that we perform epidural anesthesia, right? The onset is slower than with spinal anesthesia and may not be a good technique if the surgeon is impatient. Okay. So the disadvantages are, so normal alteration in the patient's blood pressure and heart rate. It is essential to place the block in the operating room. So whatever the normal alterations that occur with placing local anesthetic in the epidural space, like generally a decrease in heart rate and decrease in BP. Hence, all the monitoring like ECG, blood pressure and pulse oximetry should be present, and resuscitation medications and equipment should be available. Now, the risk of complications as outlined in introduction, as the neuroaxial, as we discussed in spinal. So so there's during epidural anesthesia, the disadvantages are there's continuous epidural catheter should not be used if the patient's vital signs are not closely monitored. So in the ward, it is very dangerous if the patient is not keeping an eye on the patient. It is very dangerous to give these uh, this this technique in the ward. Okay, because the epidural catheter, you cannot send the patient home with the catheter. The patients have to be monitored at all points. You cannot send the patient home with this in the back. So that is what is dangerous. So patient refusal, so infection at the site of surgery, these are absolute contraindications. So if the patient says no, it means no. Infection at the site of surgery, coagulopathy, severe hypovolemia, increased ICP, because further you are draining the CSF. So in case there is a dural puncture, etc., when you're performing epidural anesthesia and the CSF comes out, there can be coning, severe aortic stenosis, mitral stenosis, ischemic hypertrophic subaortic stenosis. So basically these are some of the any stenotic lesions. You cannot have a decrease in BP or heart rate, or increase for that matter, because there is a stenosis. So any decrease in BP will decrease the blood supply to the heart. It will cause hypotension, basically decrease the blood supply to the heart and the brain, because less amount of blood will be coming out, because first of all, hypotension, there is stenosis, so it can produce a hemodynamic collapse. So stenotic lesions are absolute contraindications, and increased cranial pressure, like I explained, hypovolemia, of course, coagulopathy, again you cannot, for the risk of epidural hematoma, and infection at the site of surgery again is uh, a contraindication. So the relative contraindications are sepsis, uncooperative patients, pre-existing neurodeficits, neurologic deficits, any demyelinating lesions, stenotic heart valves. So stenotic heart valves, it can be given, but it depends upon the severity of the stenotic heart valve. So mild to moderate stenosis, a chance can be taken. It depends on the anesthesiologist, but generally textbook wise, severe stenotic lesions, epidural is an absolute contraindication. Spinal deformity, so basically spinal deformity is pre-existing neurological deficits, because you don't know if you cause some other neurological deficit, you don't know whether it is because if it was present prior, or maybe it is a new onset. So controversial is prior back surgery, inability to communicate with the patient, complicated surgeries that may involve prolonged periods of time to perform, major blood loss maneuvers that may complicate respiration, etc. So now just a sec. Sorry. Okay. So now, so like I said, this is controversial. So some of your other complications, I'll discuss it here. This is what I did not discuss last class. So I thought I could add a slide, but it's not possible. So some of the other complications are basically paraplegia. Okay, so now paraplegia, uh, the frequency is about 0.1 per 10,000, and the mechanism of such a severe injury is basically it's multifactorial and difficult to identify. Okay, so it can be due to needle trauma, or so most often it is due to needle trauma that causes paraplegia. And the epidural needle is pretty thick, so that can cause paraplegia. So that is one complication. Also profound hypotension, so hypotension for a long period of time of the spinal cord basically. So decreased blood supply or ischemia to the spinal cord can also be a contributing factor in case of paraplegia. And anterior spinal artery syndrome can also occur, which is characterized by loss of motor and sensory function with sparing of proprioception, which is carried by posterior column. Okay, so the anterior uh, so the basically the anterior spinal artery syndrome also can lead to paraplegia. Okay, so anterior spinal artery syndrome. So basically, how does this paraplegia occur with this anterior spinal artery syndrome is the anterior cord is more vulnerable to ischemic insults because of the single, it has a single arterial blood supply, which is the this anti it is the anterior cord has only one arterial supply, which is by the artery of Adam Kiwis. I'm sure you all remember this now. I'm sorry. So your artery of Adam, Kiewicz. Yeah. So your artery of Adam Kiwis. So ischemia, because of this artery, since it is a single arterial blood supply, it can cause hypotension and or hemorrhage of this artery, can lead to paraplegia. So the anterior cord is basically it carries there is except there's loss of motor and sensory function but sparing of proprioception, because proprioception is carried by your posterior column. So there is loss of motor and sensory function basically. Okay, so this so that's what I so this artery of Adam Crease. So these are the factors that can lead to what do you call it, to lead to paraplegia. One is your needle trauma, then any profound hypotension, and of course your anterior spinal artery syndrome, where uh, anterior spinal artery syndrome, where because it is a single artery supplying the blood supply to the spinal cord, it is a single artery, and hence it can uh, if ischemia occurs in it, it can lead to paraplegia. Then we have the cauda equina syndrome. Okay, so after paraplegia, our next complication can be the cauda. Just a sec, guys. Okay, so our next thing is our cauda equina syndrome. I'm sorry, I just had to check. There was some issue, internet issues. So our next thing is our cauda equina syndrome. So basically, the cauda equina syndrome, um, the lumbosacral roots, okay, in this may be vulnerable to direct exposure of large doses of anesthetics, whether it is administered as a uh, single injection of high concentration, or if it is administered continuously through a catheter. So This can lead to the development of cauda equina syndrome. So this is cauda equina syndrome is basically seen with the lumbosacral roots, obviously cauda equina. So although small bore catheters can reduce the incidence of headache, they can predisposing to, so small bore catheters, they can we use small bore catheters to reduce the postural puncture headache. But however, this small bore catheters can lead to, accumulation of the local anesthetic in those, in the caudal region, in the lumbar sacral region, and this can basically cause this, so high concentrations will accumulate in the basal region and can lead to cauda equina syndrome. Then we have of course our epidural hematoma. So our next complication is epidural hematoma. So epidural hematoma, so any bleeding within the vertebral canal can cause ischemic compression of the spinal cord and lead to permanent neurological deficit. So like I said, any coagulopathy and all that, if the patient's coagulopathy is not checked, if the patient is on antiplatelets or the patient is on, heparin or warfarin, etc., basically any anticoagulant treatment, it can form a hematoma over there. It's a big needle. Even the spinal anesthesia can form a hematoma, cause spinal cord compression by the hematoma, and can cause permanent damage. Okay, so many risk factors have been like basically female gender, elderly age, generally elderly, because these people will be on those anticoagulant treatments basically. Then of course nerve injury is another complication. So your nerve injury again occurs because nerve injury, any direct puncture to the nerve hit by the needle, etc., can cause and lead to your nerve injury. Then we have a postural puncture headache. It's known as, sorry, it's known as PDPH, PDPH, that is your postural puncture headache. So it is quite a common complication of neuraxial anesthesia. As it implies, the postural puncture headache is believed to result from unintentional puncture of dural membrane during neuraxial anesthesia. Okay, there are two possible explanations for the cause of headache. So post-dural, after puncture of the dura, headache. Two explanation. First is because of the loss of CSF through the dura. So loss of CSF, it causes. It is proposed to cause traction on the intracranial, pain sensitive intracranial structures. So the brain will lose support. So basically there's loss of CSF occurring through the dural headache, dural puncture. So the CSF, basically the brain is losing support because the fluid is draining out. So it causes traction on the pain sensitive structures. And the second theory is the loss of CSF initiates compensatory yet painful intracerebral vasodilation. So there will be compensatory intracerebral vasodilation. So this is the second theory. Okay, so basically the loss of CSF will cause in painful intracerebral vasodilation to try to offset the decrease in the intracranial pressure. So the characteristic feature of the headache is it is frontal or occipital. So the features are, this is important, it is frontal or occipital type of headache. Okay, it is a frontal by occipital type of headache, increased with upright position and decreased on lying down. So with the seated up or upright position, it increases. It relieves by sitting supine. There can be nausea, vomiting, neck pain, tinnitus, diplopia, loss of hearing, all these can be associated with this. Okay, seizures. So the seizures and all are very rare. Tinnitus, the loss of hearing and all is rare, but it can occur. So it usually begins within 72 hours of the procedure. Okay, so the onset is within 72 hours or 3 days. Okay, anything beyond that is generally not a postural puncture headache. Okay, so they can occur in the setting of either spinal or epidural anesthesia. The former, during spinal, it is associated with the certain modifiable risk factors. During intentional dural puncture, the latter is associated with unintentional puncture of the dura by advancing the two-hoy needle. So with epidural, this postural puncture headache can occur because you advance the needle beyond the epidural space and cause dural puncture and CSF leak. So orienting a needle bevel parallel with the axis of the spine, such as the longitudinal fibers of the dura, would be more likely to be separated than cut, results in a lower incidence of post-spinal puncture headache. So if the needle bevel is parallel with the axis of the spine, so the bevel of the needle, if it is parallel with the axis of the spine, generally we go perpendicular, right? It is difficult to go parallel. So if the bevel of the needle is parallel to the axis of the spine, there is more incidence of the dura being separated than cut, and hence lesser leak, because when the dura is separated, when you take out the needle, it tends to close back. So again, the pencil point spinal needle produces a lesser loss of fluid, like we discussed, because it causes more like a flap than a break in the dural fibers, which close up on themselves. Okay, so collagen layer of the dura are oriented in multi-directional fashion, not always in a cephalocaudal direction, and are variable in thickness, leading to the suggestion that the damage is more likely to be influenced by the type of bevel and may even be predominant factor affecting post-dural puncture headache. So the fibers of this the fibers of the durameter are very zigzag, so it depends upon the basically upon the needle. So the management now, uh, so basically the factors that increase the incidence of headache are: one, a younger age. It is more common in younger age group. It is more common in females than in males. It is more common with a larger size needle than a smaller size needle. The needle bevel, it is less when the needle bevel is placed in the long axis of the neuraxis. Basically, when it is placed, then the bevel is parallel to the nerve, to the back. And pregnancy, it is more seen with pregnancy, and occurs more with multiple punctures. So female age, pregnant, young patients, multiple punctures, fat needles, and depending upon the direction of the bevel, this is more commonly seen. It is unrelated. This post-dural puncture headache is unrelated to the time of ambulation. It does not mean that 72 hours you cannot ambulate, must not move because regional anesthesia is given. No such thing. And of course, it increases and no relation to catheters. So the management is basically conservative. Hydration, coffee, analgesics like what do you call it? Analgesics like uh, paracetamol, etc., can be given. And after a week, if it still doesn't subside, epidural blood patch is the definitive treatment. Okay? So epidural blood patch is your definitive treatment. Okay, it is performed 24 hours after the dural puncture and after the development of the classic symptoms. So till 24 hours, it is not performed. Uh, so basically, it is not suggested to prophylactically do this. So the around 15 ml of the patient's blood will be injected into the epidural space, and it is said that that 15 ml will spread around 9 segments, and the direction of spread is preferentially cephalad relative to the level of blood injection. So as a result, it is recommend inserting the blood patch needle uh, at caudal to the level of the previous dural puncture. So basically 15 ml of blood, it is said to spread more cephalad. So wherever the puncture has been done previously which has caused the headache, it is preferable to inject this blood below that segment. Okay. So 15 to 20 ml is the target blood volume that should be inserted into the epidural space, and a second epidural blood patch may be performed 24 to 48 hours after the first one. Then the last complication is transient neurological symptoms that can occur. Again, this is related to the concentration of the it is more associated with lignocaine, and it is described after intrathecal administration in of this it's basically a radicular irritation. Transient, it's very transient neurological symptoms. It's a radicular irritation, and it is characterized by bilateral or unilateral pain in the buttocks radiating to the legs, and less commonly it is isolated to the buttocks or the leg. Usually it involves the buttocks and the leg, and the symptoms occur within 24 hours of an otherwise normal spinal anesthesia or epidural anesthesia, and there is no neurological deficits. It's just a transient syndrome, right? It occurs more for patients who are placed in the lithotomy position for surgery. Non-steroidal and inflammatory drugs are the first line of treatment, but pain can be severe and may require opioids. Uh, so it is the incidence is higher after intrathecal lignocaine and mepivacaine, and so transient neurological symptom it is less with bupivacaine, and it is related basically to the concentration of lignocaine and the addition of dextrose or epinephrine to alter the osmolarity. Okay, the type of needle also can result in TNS. um, so the double orifice needle reduces this TNS considerably, because the single orifice needle increases the risk of injecting it into the thecal sac. So single orifice will concentrate the drug, but double orifice it will spread a little more. It is not commonly associated with epidural procedures, but is seen. So basically, the mechanism is in epidural, the drug is administered at a distance compared with spinal anesthesia, where it is administered just close to the spinal cord. The target is the spinal nerves and associated nerve roots, and various barriers to the spread of local anesthetic to the intended site of reaction. That is why, because it has to pass through the it's being deposited in the epidural space, not after the dura. So there are various barriers, so more volume has to be given. So the barriers are dura mater between the epidural space and the spinal nerve roots. Majority of the solution will get absorbed by the venous plexus, and the rest can go into the fat, and hence the amount that reaches the spinal nerve is less, so a larger volume has to be given. So the spread in the epidural space, basically the spread is more horizontal and longitudinal. Okay, so the longitudinal spread could reach the foramen magnum and sacral magnum foramina if enough volume is injected. Horizontally, of course, the local anesthetics spread through the intervertebral foramina to the dural cuff. Local anesthetics spread through the dural cuff via the arachnoid villi into the CSF. So they reach the CSF through the dural cuff via the arachnoid villi. So it takes 6 to 8 times the dose of spinal anesthetic to create a comparable block, because these are larger nerves that are found in the epidural space when compared to the subarachnoid space, and the local anesthetic has to penetrate the dura mater, the arachnoid mater, the fat absorption. It has to counter all that and then reach the nerves. So they are absorbed into, like I said, so the local anesthetics gets absorbed into the epidural veins, and basically the pulmonary system, it can get exhaled through the pulmonary system too, and of course distribution to the vessel rich organs, muscle and fat. That is the normal distribution of local anesthetics. So long acting in the CSF, basically what you need to see, amides are basically metabolized in the liver. Esters are metabolized, ester local anesthetics are metabolized by pseudocholinesterase. However, you need to remember in the CSF, these ester local anesthetics, there is no pseudocholinesterase and they are metabolized basically by uptake from the blood. So the long-acting amines, they are protein bound and will bind to alpha-1 globulins, which have a high affinity for local anesthetics. So these are some of the factors that affect local anesthesia, that affect the epidural block. So volume of the anesthetic, of course, the amount that is given. Then coming to the height of the patient. So height of the patient, okay, age of the patient. So basic, when it comes to the volume and total mass of the inject are the most important drug related factors. So this is the volume of the drug is the most important drug related factor. Administration of local anesthetic, 1 to 2 ml solution should be injected per segment to be blocked. So 1 to 2 ml per segment to be blocked. Okay, I think it's here. So 1 to 2 ml per dermatome to be blocked. That is, if the epidural is placed at L4, L5, you want a, sorry. If the epidural is placed at L4, L5, you want a T4 block for a C-section. You have 4 lumbar vertebral dermatomes and 8 thoracic dermatomes. So you want you've placed it at L4, L5. You want to go till T4. Between these two, you have 4 lumbar and 8 thoracic. That is 12. So 12 into 1 to 2 ml will be your 12 to 24 ml. Okay. This is a big dose and hence incremental dosing, cannot give the volume immediately. If you require only segmental anesthesia, then doses would be less if only one particular part has to be blocked. Volume of the anesthetic plays a critical role in the block height, and dose of anesthetics in the thoracic area, thoracic vertebrae should be decreased due to decrease in compliance and volume. Age, now patient factor, age actually influences the epidural block height. Okay, so it is because 40% less volume is generally required in the elderly. This could possibly the reasons could be decreased leakage of local anesthetic to intravert. There's decreased compliance of the epidural space in the elderly, resulting in greater spread and increased sensitivity of the nerves in the elderly. So there is decreased compliance of the space and increased sensitivity of the nerves. Right, so decreased compliance and increased sensitivity of the nerves. As with spinal anesthesia, it appears that only the extremes of age of patient height influence the local anesthesia spread in the epidural space. Weight is not well correlated with block height. Weight has nothing to do. So less local anesthetic is required to produce the same epidural spread of anesthesia in pregnant patients. This may be in part because of progesterone effects as well as engorgement of epidural veins, abdominal pressure, and of course continuous positive airway pressure also. So ventilation also increases the height of thoracic epidural block. So the shorter the patient, the less local anesthetic required. So the epidural space is collapsible, distensible. It is collapsible and distensible reservoir through which the drug can spread. Through which the drug spread are removed by, the drug is of course removed by diffusion, vascular transport, leakage. So spread of anesthetic within the epidural space and subsequent block height is related to a variety of factors. All can be manipulated by the anesthetist. So basically drug volume, elderly patient, pregnancy and the level of injection can affect the drug height. Then the less important are basically the concentration of the anesthetic is not important. Weight, height of the patient, pressure in adjacent body cavities and all is not very important. So position of the patient does affect spread and height of local anesthetic but not the point of spinal anesthesia. So the lateral decubitus position, basically gravity will, so the lateral decubitus will concentrate local anesthetic more to the dependent side if the patient is kept in that side for a longer period. So for the saddle block sitting position, will have more local anesthetic delivered to the lower lumbar and sacral dermatomes. So some with gravity, sometimes the L5S2 will have patchy anesthesia due to sparing. So when you have it, basically when you have the patient sitting, okay, during spinal anesthesia, if you want it, if you want the anesthesia, if you want the um anesthesia confined only to the perineal region, make the patient sit for another 3 minutes. The anesthetic will settle down low and only the perineum will be blocked. Again, your Trendelenburg and reverse Trendelenburg. So Trendelenburg basically head down, reverse Trendelenburg head up, may help spread the local anesthetic cephalado caudal. Okay, so the head up, head low, the anesthetic will spread. So soon after giving the anesthetic, patient should be made to lie supine and table changes should not be made immediately. Of course, you can give a head up position because so that the drug does not ascend and cause respiratory distress. Now, some of the local anesthetics that are used for epidural are, so in choosing, the potency and duration of the local anesthetic has to be kept in mind, of course. So the potency and duration of the local anesthetic, surgical requirement, the duration of the surgery and how much relaxation is required, and post-operative analgesic requirements. So all these have to be kept in mind. For epidural, preservative-free solutions are used. Even for spinal, preservative-free solutions. The label should be read to ensure it is preservative-free, not expired, and okay, that is very important. Preservative-free and not expired. So the local anesthetics that can be used, short acting and intermediate acting local anesthetics. Short acting is basically your chlorprocaine, and your intermediate acting is lignocaine and mepivacaine. So lignocaine basically is available as 1 and 2% solutions. So lignocaine is available as 1 and 1 to 2% solutions. Okay, and it has an onset is within 10 to 15 minutes. So onset is within 10 to 15 minutes, and the duration of block will be up to 120 minutes. Okay, so it can be extended up to 180 minutes by the addition of epinephrine. I will come to additives next. So unlike with spinal, transient neurological symptoms, we just discussed it. So like with spinal, this transient neurological syndrome or symptoms is not common with epidural anesthesia. Okay, so transient is basically because, like I said, there is concentration of drug in that space, pooling of drug in that space, more seen with your single tip catheters, not with your double tip catheters. Double tip causes more spread, so single tip will cause more concentration. So this transient neurological syndrome is more common with a single tip, and it is more not seen so much with epidural, but it is a complication of lignocaine anesthesia. And then you have your long acting like bupivacaine. So your bupivacaine is basically levobupivacaine, ropivacaine, etiodocaine. But your bupivacaine is available as 0.25%, 0.5%, and 0.75%. Okay. Preservative free solution, onset is around 20 minutes. So it takes a longer time for onset, so it can be bridged with this lignocaine because the onset is shorter. The duration of action for lignocaine was, like we saw, 120 minutes. However, for bupivacaine, it is around 225 minutes, much longer. And if you add epinephrine, it is further increased to 240 minutes. Okay, So more dilute concentrations like 0.125, these are the more dilute concentration. 0.125, 0.25 or 0.625 are also available. These are the analgesic doses basically. They are used only for analgesia. These are used for analgesia as well as motor block. These are used for analgesia as well as motor blockade. Okay, so solutions of basically 0.5 and 0.75 are used to provide surgical anesthesia, like I said, the motor block. Liposomal bupivacaine is currently under investigation for epidural use, um, but it's not yet being used. Does not appear to be toxic and all, but still it is not yet in use, liposomal bupivacaine. Um, it acts, so the liposomal bupivacaine, it basically acts as an extended release, for morphine and all we have these extended release patches and all that. So this liposomal bupivacaine deposited into the epidural space acts as a extended release of bupivacaine, and it lacks the need for an epidural catheter. So basically you don't need to insert a catheter there. You can put this liposomal um, bupivacaine, but the problem is it is not titrable, right? With the catheter you can titrate your dosage. With this liposomal, once you deposit them, you cannot titrate the dosage. So we discussed, it is a lignocaine is an amide local anesthetic, 1.5 to 2% concentrations used. Epinephrine will prolong the duration of anesthesia by 50%. Addition of fentanyl also will accelerate the onset of analgesia and create more potent complete block. This is what we just discussed just now. Okay. So its onset is intermediate, around 15 minutes. 1.5% causes sensory as well as motor blockade, 1.5 and 2%. It normally it will take around 120 minutes with epinephrine. 1 in 2 lakh, it takes 120 to 180 minutes. The dose is 3 milligram per kg. This is the toxic dose. 7 milligram per kg with adrenaline. This is for bupivacaine 2. 7 milligram per kg is the highest with adrenaline. So lignocaine toxic dose is 3 milligram per kg. Bupivacaine is 5 milligram per kg. Prolonged action reduces the toxicity. Again, your bupivacaine, local acting amide local anesthetic, 0.5 to 0.75% concentrations are used. 0.125 is used for surgical anesthesia. Your 0.125 and 0.25% are used for analgesia. So this is your analgesic dose and this is your dose for surgical anesthesia. This is very important. Please keep this in mind. So epinephrine will prolong the duration of action but not to the extent of lignocaine, mepivacaine and 2-chloroprocaine. So 0.75 concentration should not be used in obstetrics. Okay. There are several cardiac, so bupivacaine is more cardiotoxic. So in these patients, higher concentrations, since the cardiac, because of the hormone progesterone, everything is sensitized extra in these patients. So more propensity to result in cardiac arrest. So it is now generally not used in obstetric patients. Then of course bupivacaine as well as epidural are more likely to impair the myocardium and conduction system because more toxicity. Bupivacaine has a high degree of protein binding and lipid solubility, hence a long duration of action. This of course can lead to accumulation in the conduction system and result in the refractory arrhythmias. So as you can see, less than 0.25%. Sensory block is dense, but the motor block is minimal. With the longer acting concentrations like 0.5 and 0.75%, the onset is same. It's not slow. It causes dense sensory and motor blockade. Duration of action is 220 up to 225 minutes with the plain solution, and with epinephrine it is around 240 minutes. So bupivacaine is long acting, 4 to 6 hours. It causes sensory more than the motor blockade, and dose is generally 1 to 1.5 milligram per kg. It is cardiotoxic, and there is of course no tachyphylaxis with these drugs. So your levobupivacaine, now it's a newer drug. It is basically the S isomer of bupivacaine. So lesser, basically the S isomer has lesser cardiac toxicity effects. It is used in the same concentrations. Okay, so basically long acting, it is long acting, so less than 0.25%, more sensory block, 0.5 to 0.75. The sensory block is same, it causes sensory as well as motor block. Onset is the same, up to 225 minutes and 240 minutes with epinephrine. So long ropivacaine is a long-acting amide local anesthetic, mepivacaine analog. It is used in concentrations of 0.5 to 1% for surgical anesthesia and zero point 0.1 to 0.3%, so 0.1 to 0.3% for analgesia. Okay, ropivacaine is unique since it exhibits a vasoconstrictive effect at clinically relevant doses. So at clinical doses only, ropivacaine exhibits a vasoconstrictive action. However, ropivacaine has a slightly shorter duration of action than levobupivacaine and bupivacaine. Um, okay, uh, but it has a similar clinical profile, shorter duration of action, less motor blockade. However, the reduced motor blockade may in fact reflect different potencies of the drug rather than a motor sparing effect. Okay, it is less potent than bupivacaine, so it is less potent than bupivacaine. More amount has to be given, and it is less cardiotoxic than it has a lower seizure threshold. I'm sorry. Bupivacaine has a lower seizure. Ropivacaine is less cardiotoxic. Okay, so it is similar in onset, duration, and quality of anesthesia. The key differences in doses for analgesia, there is excellent sensory blockage. So this has a so again it is less cardiotoxic, but the incidence of seizures is more with ropivacaine than with bupivacaine. And here it is the motor blockade, it produces a short, it produces a lesser motor blockade as compared to levobupivacaine and bupivacaine. So as you can see, 0.1 to 0.2% sensory blockade, zero point 0.5 and 0.75 it produces dense sensory blockade, and mild to moderate to dense motor blockade depending upon the dosages. So local anesthetic systemic toxicity, they can be tingling around the mouth, drowsiness, hypotension, seizures. Treatment is maintain your circulation, anti-seizure medication like midazolam and thiopental, and intralipid can be given to reverse the local anesthetic systemic toxicity. I have discussed this in the local anesthetic class. Now coming to the epidural additives. So epinephrine, epinephrine will increase the duration of action of all epidurally administered local anesthetics. Okay, there is large variability among local anesthetics to the degree of increase of duration. So the greatest effect, so it increases the duration greatest with lignocaine, mepivacaine, and 2-chloroprocaine, and it increases the duration lesser with bupivacaine, levobupivacaine, and iducaine. As a result, epinephrine is usually added with lignocaine. Okay, and with the ropivacaine it has minimal effects. Epinephrine versus phenylephrine. Epinephrine is more effective in reducing the peak blood levels. It causes vasoconstriction and hence less absorption. Phenylephrine does not appear to reduce the peak blood levels. Now carbonation of local anesthetics, basically so basically local anesthetic preparations have a pH between 3.5 and 5.5 for chemical stability and bacteriostasis. So at these low pHs, a higher proportion of the drug is in the ionized form and therefore unable to cross the nerve membranes to reach the binding sites on the sodium channel. Okay, so basically the pHs of local anesthetics is generally 3.5 to 5.5. At this low pH, this is for this is done to promote chemical stability and also to prevent bacterial growth. So it is made more acidic. But however, more amount of the drug is in the ionized form, hence less amount of drug is available for action at the sodium channel. So as a result, this carbonation is done. So carbonation is done to improve the quality of epidural blocks, okay, to increase the penetration into connective tissue and intraneural diffusion. Okay, so that is why the pH is increased, to increase the basically the unionized form of the drug. Okay, so carbonation may not improve quality of onset, may lead to increased blood levels of local anesthetic and result in higher incidence of hypotension. So this is the side effect. Okay, so theoretically carbonation with the more unionized forms should increase the speed of onset and quality of block. Okay, so ideally it should act like that. So sodium bicarbonate can be added to lignocaine, mepivacaine and chlorprocaine. Addition will increase the amount of free base, which increases the diffusion and the onset of action. So generally 1 milli equivalent of bicarbonate is added to 10 ml of local anesthetic. The addition of bicarbonate to bupivacaine is not popular, as 0.1 ml has to be added to 10 ml of bupivacaine if needed. So basically bupivacaine precipitates at pH of more than 6.8, so it is not advisable. So mixing long acting and short acting local anesthetics may not have much advantage for epidural anesthesia. Many choices for local anesthesia and additives are available. So you can mix uh, basically a lignocaine to bridge the duration of action. Now your bupivacaine takes long to initiate action. It takes around 20 minutes. However, your lignocaine within 10 to 15 minutes the action starts. So a bolus dose can be given of lignocaine at the beginning of the surgery so that there is relaxation, and then an infusion of bupivacaine can be started so that lignocaine will bridge the time for onset of action of bupivacaine. So guys, that's it for today. That was my class on that completes our local our regional anesthesia topics, and I'll be preparing a quiz on this soon and you all can access it. So today on the special class platform on the app, I will be conducting a quiz on and discussing a quiz on positioning in anesthesia. I had finished that topic in 2 classes, and tomorrow this evening at around 6 p.m. I will be taking up a quiz on that subject. So guys, like I said, please use my code SASHA to avail your 10% discount, and please subscribe guys. Okay, have a good day, study hard, study well and keep practicing. Thanks guys.